Who can tell me in just a quick sentence, what's the purpose of our heart? To pump blood. That's a good answer. We need to get oxygen to all the cells in our body, and the oxygen travels on the little red blood cells. Those are the little boats that float around in the bloodstream, and the heart pumps it all around. How many chambers do we have in our heart? 4. That is correct. We have 2 chambers in the upper part of the heart. Those are called the atria. And we have 2 chambers down in the bottom of the heart called the ventricles. So 4 chambers. How many valves do we have in our heart? Not as easy as the first question, right? We have 4. 4 chambers and 4 valves. If you think of each chamber like a room, and you think of the valve as a one-way door leaving that room, so the blood only flows in the direction that you want it to go. So there are 2 valves in between the 2 chambers in the upper and lower side of your heart on the left, and then on the left and the right side. And there's also a valve leaving the ventricles, one going to the lungs and one going to the rest of the body, called the aortic valve, which leads into the aorta, which is the largest artery in our body. Also on the inside of the heart, the ventricles are big, thick muscles, where the atria are just smaller and thinner. If you are in atrial fibrillation or atrial flutter, if you've heard of that type of arrhythmia, what's happening is the upper chambers of the heart aren't really pumping blood. They're just kind of wiggling around. And so the ventricles are doing all the work when you're in that arrhythmia. And the heart can work about 85-90% efficient without the atria, but these give it a little extra kick and make the heart work most efficiently. The right side of your heart pumps blood only to the lungs, and the left side of the heart pumps blood everywhere else. Okay, there's some people that may want to come in the class. We let them in. The left side of the heart pumps blood everywhere else. And so this is the part of the heart, this left ventricle, that does most of the work. And when they want to measure how well your heart's working, what they do is they measure how much blood your left ventricle can pump out. And they call that the ejection fraction. And it can be measured with an echocardiogram. It can be measured with an angiogram. There's a couple ways of measuring how much blood this left ventricle can pump out. Now when it's full and it squeezes, it should pump out about 55 to 70% of what's in there. That's normal. So if your ejection fraction, which is a percentage, is 50%, then it's just a little bit below normal. And if it's 20%, then it's not pumping very well. So you kind of have a reference of how well your heart's working by this number called the ejection fraction. And most of you, if not all of you, have had this measured, and it's in your chart. If you're curious of what the number is, ask the staff person that's working with you during your exercise, and we can look that up. Okay, that's the inside of the heart. The heart is a muscle in itself, and it also needs blood. So if we're looking now on the outside of the heart, once blood is pumped out of the heart and into the aorta, the aorta arches around back behind your heart, follows along your spinal column, and then all these blood vessels coming off of it to your arms and your head and your legs and everywhere else. The heart gets its blood flow from the coronary arteries. And the coronary arteries are little vessels that come off of the aorta on the right and the left side. And the right side kind of wraps around to the back of the heart. The left side splits in two. One comes down the front, and one branch goes around the back of the heart. So there are three major branches, or three big tree trunks of branches that are feeding your heart, with all of these other branches coming off of it. Okay? Now, what happens if this artery suddenly closes off right here?
Pass out.
Well, you might pass out, but you're likely to have some symptoms. What do you call that?
Heart attack.
It's called a heart attack. When an artery completely closes off suddenly, everything downstream from that, and in this scenario, that would be all this front side of your heart, is not getting blood flow at the moment. And the sooner you can get treatment and the sooner you can get that artery opened up, the more of this heart muscle that's going to heal and recover and come back. And the longer you go, the less likely that part of your heart muscle will recover and come back. Now, where the blockage is how important it is, how significant. If this is blocked up here, this doesn't look very good to lose all that part of your heart muscle. If you have a little tiny, tertiary branch way down here that's feeding part of your heart muscle the size of a dime, you're likely to still have some symptoms, but you're probably not going to have, when you recover from it, any change in how you feel or what you're able to do. But you've lost a little bit of heart muscle. So where along the line that blockage is to how significant it is. So what we're going to talk about today are what are the things that put us at the greatest risk of having blockages in our arteries in the first place. And cardiovascular disease, as you probably know, is the #1 reason why people in the United States die. And so we want to lower our risk of cardiovascular disease. So to do that, we need to know the risk factors. There are 10 major risk factors for heart disease. There's 3 of them that we don't have any control over, and we call these uncontrollable risk factors. Fortunately, most of them we have some control over, meaning we have control over our risk. And we can modify these risk factors either through exercise, through the way that we eat, through medications, through managing stress. So there are things that we can do to modify and lower our risk for heart disease through most of these risk factors. What would be something that would put you at risk of having a heart attack or blockage in your artery that you didn't have any control over? Genetics. Yeah, we call it family history. And when you get the little check in the box that says you have a family history, the criteria is if you have a first-degree relative, that would be a parent or a brother and sister, who have had cardiovascular disease less than the age of 60 years old. So if they've had a heart attack, they've had bypass, or they have some known blockage in their artery, less than the age of 60 years old in a parent or a sibling. That's sort of the hard and fast where we draw the line. Now there's obvious shades of gray. What's the difference between 59 and 61? But that's kind of where we draw the line. If you have had a parent had a heart attack at age 40, then you have a strong family history of heart disease. Now, we can't change our family history, but what the risk factor does is it tells us how aggressive to be with treating all of your other risk factors. So if you have a strong family history and your blood pressure is borderline and your cholesterol is borderline, we don't fiddle around with just letting that go. They're going to treat you probably more aggressively. Even younger people may get put on medicines sooner. And then as far as the guidelines, what your cholesterol should be, what your blood pressure should be, if you have a family history, again, you want to get those numbers close to lower targets as possible. Okay? So that's how we approach a family history. And genetics account for about 1/3 of your risk, especially in people who have a family history. But fortunately, even with a family history, most of your risk is determined by your own risk factors and your own lifestyle. And that's good news. You're kind of in control for the most part. What would be another thing that would put us at risk that we didn't have control over? Okay, your age. Is that what you said? Yeah, that's correct, is age. And the way we tease that out is by men and women. So for men, as well as women, but for men, when you're young, at the age of 20, you have a pretty low risk of having a heart problem in the next 10 years, regardless of how you treat yourself. You know, we can, our body is resilient, and we can do a lot of things to it for a while. So when you're young, your risk is low. And that risk stays low for men until about the age of 45. And then at the age of 45, every year after that, the risk goes up just a little more and a little more. The number one risk factor for dying is age. So age increases your risk. And for men, it's a low risk until the age of 45. And then the risk gradually starts to go up a little bit every year after that. For women, where does a woman's risk of heart disease start to increase? 50. She said 50. Not a bad guess. It's not an age, though. Menopause. So for women, after or post-menopause is where the risk starts to increase. Now, you don't have a low risk right before menopause and a high risk right as you're going through it. It's gradual, but that's where you go from low risk to every year a little bit after the risk increases. Now, one of the things that's been looked in and still is being studied and researched is there anything we can do to treat this or lower your risk? Basically in the way of giving hormone replacement therapy. And if it's so good, why don't we give it to men too? The 10 or 15 years ago, the thought was to give hormone replacement therapy to lower your risk of heart disease. That was the thinking for a few years, and then they backed away from that. There are reasons why you might take hormone replacement therapy if you had a family history of osteoporosis. It may actually help improve bone density. But if you have a family history of breast cancer, then you probably don't want to take hormone replacement. But what we're talking about is trying to prevent a heart attack. And there's some evidence to show that maybe as you're just going through menopause, hormone replacement therapy might have some benefit. But if you're well beyond menopause, there's no benefit as far as preventing a heart attack. Okay? So these are the uncontrollable risk factors that we kind of have them and know that we have them, and then also to know how aggressive to treat all of these other ones. Now there are 7 other major risk factors for cardiovascular disease. What's one of them? Smoking, good answer. We usually consider smoking or tobacco use, because you don't have to smoke it for it to be bad for you. We consider that if you're actively using tobacco, and you've used tobacco in the last 6 months, then it's a risk factor. And we consider that your number one risk factor. until you stop, and then something else is. What's another risk factor? Okay, I've heard a couple things. I heard diabetes, I think, in there. Diabetes is a chronic disease in itself, although it's a major risk factor for heart disease. I heard lack of exercise, I think. Okay. I'm going to talk about these individually here, but we're going to list them on the board. What's another one? Obesity or just being overweight. Okay, another one. Your diet affects your health, depending on whether you eat well or poor. And diet also affects some of these risk factors. One in particular would be cholesterol, for example. So I'm going to just put that. High cholesterol, it also impacts your weight, your blood sugar, and those things. Stress. Good. One more major risk, blood pressure. Good. You guys did very well. There are other things that we know that can put us at risk for developing cardiovascular disease. There are some enzymes in the blood that we know make your blood clot a little easier. They found these enzymes, one called homocysteine, one called fibrinogen. And most of you probably have not had those measured. But they found in people who have had heart attacks have higher levels of these enzymes that make your blood clot a little easier. And they found that they can actually lower those and treat them with B vitamins. There's also an inflammation marker. They can draw blood and measure the inflammation in your blood, which is suggestive of some buildup of plaque in your coronary arteries. The environment in which you live in, the air quality, can impact health in general, not just heart disease, but cancer and diabetes and other things. Alcohol is something that people suggest. We know that drugs and excessive alcohol use is not good for anything. It's not good for the heart. Alcohol is actually toxic to the heart, especially in large volumes. People who are alcoholic all their life, we know, have bad livers. They usually have a bad heart too. Big baggy heart that doesn't pump very well. But in moderation, a little bit of alcohol might have some benefit. There have been studies with red wine to show that people that drink a little bit of alcohol have less heart disease than people that drink a lot, and less heart disease than people that don't drink at all. And there may be some social factors involved with that. We also know that there's some very good properties in the grapes themselves. And there have been studies with the grape juice without the alcohol have shown a pretty similar benefit. So you don't need to start drinking alcohol to lower your risk, but if you do a little bit now and then, it probably will be okay. And a little bit means no more than a drink or two a day occasionally. All right, so these are the ones that we know in people who develop blockages in their arteries. These risk factors show up time and time again. And these are the ones that have the greatest impact. So I'm going to start with smoking. We know that smoking is bad for us. I think people that smoke know smoking is bad for them. We hear a lot about how it's bad for your lungs, which it is. It can cause lung cancer and emphysema. But most people who smoke die from their heart and not because of their lungs. Why do you think smoking is so bad for your heart? Affects the arteries? It's kind of a leading question, and I'll get into a couple things. But basically, you're breathing all these toxins in to your lungs, and the air that we breathe in, a lot of the stuff in there gets dissolved into the bloodstream. So everywhere that blood is flowing can impact those arteries. So we talk about heart disease, but it's really all of your cardiovascular system. People that smoke long-term may even get blockages in arteries going to their legs, and similar to people who have diabetes. It can block up little small arteries going to your eyes and your kidneys and your heart. Your heart has small blood vessels. I think last week we passed around a little, did Sarah pass some props around and show you how small a stent actually is? Those small arteries get clogged up first before the big ones, the big aorta. I'm going to draw a picture here of an artery. Remember, arteries are muscular, where veins are just stretchy and they can hold blood, and veins bring blood back to the heart. Arteries, there's a lot of high pressure in arteries, so they need to be stronger. They need to be able to relax and dilate, and they need to be able to constrict at certain times. So arteries are muscular, and they have a thin lining that's one cell thick. It's called the endothelium, but it's basically the lining of the vascular bed. And it releases nitric oxide and allows the artery to relax, and so it does things to protect the artery. So anything that injures or damages the inside layer of your artery can cause a buildup of we call it plaque, all the goopy stuff and all the scar tissue and all that stuff that builds up in the arteries and starts getting in the way. We just call it plaque. And these things, tobacco and all the chemicals that are in the smoke and the nicotine, which is a stimulant, high blood sugars over long periods of time, all the stress hormones that are important when you need to fight or flight, in an emergent situation. But that system can take a toll on your body if you call it up 10 or 12 times a day. High blood pressure over long periods of time. We know that when you're working out, your blood pressure goes up, and that's fine. You can handle a high blood pressure for 1 hour a day, as long as it relaxes the rest of the day. But over time, anything that injures and damages the artery, it's not too different than if you were to injure the outside of your body. If you cut your arm, it bleeds, right? And then it clots up, and then eventually it swells, and then it forms a scar. And the scar, the repair, doesn't look like what it looked like to start with. And a similar type of thing happens inside the arteries. It gets damaged, repairs itself, but it doesn't look the way it used to. And you do that time after time for decades, and you get sort of a buildup of stuff in there. And most of it is kind of hard, fibrous scar tissue, and some of it's more goopy stuff like swelling, inflammation, and cholesterol, which is involved in the healing. And I'll go into a little bit more of that, but the way it starts is this stuff kind of starts underneath and in between the layers of the artery itself. So it starts to kind of bulge out a little bit. The artery is trying to stay open, trying to get blood down to that muscle down at the end there. And so you get all this stuff underneath and inside the walls of the artery. And it happens pretty early in life, the start. In autopsies they've done on teenagers, they usually see these little fatty streaks on the walls of the arteries. They can usually tell which kids eat at McDonald's and smoke and which ones don't. So it starts early, and depending on your genetics and your lifestyle and your risk factors is the if and when that ever builds up and becomes more of a problem. And as it does build up, eventually it gets so big that it does kind of poke back into the center of the artery here. Now, you have to block off an artery about 70% before it even starts to interfere with blood flow. So in other words, you could have a 50% blockage and it doesn't impede blood flow. You can be stressed out. You can run a marathon. You can take a stress test and pass it, and then have a heart attack the next day. All of this stuff is building, and it takes usually decades to build up. But it has to get to about 70% before you start having like angina symptoms. Those of you who know angina or chest pain, they will not go in, the cardiologists and the surgeons will not do an intervention on a blockage that's less than 70%. You can't put a stent in there or do a bypass because there's no need to. When I get to cholesterol, I'm going to talk a little bit more about this buildup of plaque. Some of them are stable, some of them are unstable. The ones that are unstable are the ones that sort of break and crack and cause the problems, cause the blood to start clotting there and close the artery off. So how big it is, but also how stable it is to whether it's going to turn into a heart attack or not. And what we want to do is we want to stabilize it, and then we want to keep it from growing to be a problem. So my point initially here is that it starts early in life, and there are a number of risk factors that contribute to it. Okay? And we'll go into a little more into that. One of those risk factors is smoking, and secondhand smoke is just as bad. If you were to follow a smoker everywhere they went and shadow them around, you'd have about the same physiological effects as if you were smoking yourself. So the more you get away from that, also the better for your health. One of the good news, if there is about this, is that it's not too late to quit. Because if you continue to use tobacco, you're continuing to irritate the artery. Either an artery that they're treating with medicines or an artery that they just did a bypass or put a stent in, and you're continuing to irritate that. There are two things that if you really like hospital food and you want to go back for some more, one is to keep smoking, and the other is to have diabetes and not have it under control. Those are two really big ones. If you stop smoking and you're a long-time smoker and you quit and you haven't smoked for a year, your risk of having a heart attack is cut in half. And if you smoked a long time ago when it was cool and all the doctors were advertising cigarettes, but you haven't smoked for 15 years or more, your risk of having a heart attack moving forward is the same as if you haven't smoked. So stopping is the ultimate goal, and it's never too late because you lower your risk immediately when you stop. Now, we know that's not so easy for some folks. Some quit cold turkey, others struggle with it. And so we do have a tobacco cessation program, call it the Options Program. And that's also why we continue to ask you about it when you come in. We just want to check in with you. So that's the first major risk factor. Next one is overweight. What % of adults do you think in the United States are overweight?
60.
I hear 60.
70, 80.
70 or 80. It's kind of like an auction, huh?
Yeah.
It's about 2/3. The last data that came out from a couple years ago is about 65% of adults are overweight. Now that we said that, what does it take to be overweight? I have a handout that I'm going to pass around here. There's a little graph on it. It's called the Body Mass Index, or the BMI. You likely have heard of this or seen this before, but it's a formula based on your height and your weight. And based on your height and your weight, you get a number, which we call the Body Mass Index, or the BMI. If your body mass index is 25 or greater, that's overweight. If it's 30 or greater, that's obese. And there's other categories above that. So if you're looking at that and figuring it out, it doesn't take a lot to be classified as overweight, maybe 15 or 20 pounds over what would be ideal. Now, the numbers aren't just arbitrary. The reason they developed those numbers, I'll draw a little graph here. The ideal body mass index is between 18.5 and 25. So based on your height and weight, if your body mass index falls between 18.5 and 25, those are the people who tend to have the lowest health risk, both heart, diabetes, cancer, other chronic illnesses. People have the lowest amounts of those chronic diseases in between those ranges. Now, after 25, you can see the graph starts to go up a little, and that's why we say right after 25, the risk goes up, so that's where the overweight line is. And again, there's another change in the curve at 30. Now, on the other end of the scale, of course, if you're too much underweight, then that also poses some other health problems. So this is the ideal range. Now, if you're 35 or 40 on a body mass index and you lose 10 or 15 pounds, you may have a significant change in your health risk. So being a little bit overweight and losing a few pounds can be good for you. But if you're a lot overweight and you lose 15 pounds, that may be enough to improve your blood sugar, your blood pressure, and do a lot of other good things to lower your risk. Now, the other thing here that's important to talk about when we talk about weight, because the body mass index does not say anything about how much is fat and how much is muscle. So if we look at a couple different body shapes, this person with a thin waist and carry their initial body fat below their waist and their hips and thighs is said to have a pear shape, where, what do you call this other person with it in the upper torso? The apple, correct. If these people are the same height and they weigh the same, so they have the same body mass index number, is one of these people at more health risk than the other?
Yeah.
And which one? The apple, correct. Storing extra fat around the midsection, we call this abdominal obesity or central obesity, is worse for your health. It's more atherogenic, so in other words, more likely to cause atherosclerosis, heart disease. And it's also the number one risk factor, that and inactivity, for the adult type diabetes. So you might be tall and thin and have a normal body mass index, but if you're carrying a lot of weight right here, so we tend to see this in men a lot, tall, thin guys with a big stomach, don't think that because they have a normal body mass index that they're necessarily healthy. If they're not exercising and they're putting a lot of weight around their stomach here, they're looking at diabetes or prediabetes. One of the other things I'd like to say here is that of people who have had a cardiac event, 80% fall into the overweight category. So we know that most of you coming through here are trying to lose a few pounds. And a typical program is about 3 months. How many people do you think come through our program and lose like 30 pounds in the 12 weeks? A lot? 30%? Even less than that. And for the most part, it's not because people aren't trying. Part of it is there's a lot going on that you don't see. One thing that happens is that people start to lose a little bit around the midsection when they start eating better and they start exercising. So you can hop on the scale and you can see after all this hard work you've put in, you've only lost 5 or 6 pounds. That could be discouraging. You might just say, well, I might as well have the pizza and the beer and the extra 5 pounds. But what you don't see is that this losing around your midsection, you go to the next belt loop, or you just measure and your waist is thinner. That is very significant for lowering your risk of continued or future health problems, heart or otherwise. So if you only lose a few pounds but you've lost around here, you should consider that a success. And we only see a short period of time. You keep doing what you're doing and you'll continue to make progress. It took a long time to get to where we all are today, and it may take a little time to change things if things need to be changed. So I like to say that to encourage people, because there's more to look at than just the scale. So I'm going to segue from weight into diabetes. Yeah.
What was that 80% figure you used in regard to that?
Well, the question is about the 80% figure. Of the population of the United States, the adult population, 65% of adults are overweight based on this criteria. Of adults who have had a cardiac event, so we've got another population, 80% of people who have had a cardiac event are overweight. Or overweight, yeah. So being overweight and inactive can lead to diabetes, or at least to the risk factors of diabetes. Diabetes is basically your body's inability to control your blood sugar in the appropriate range. It can't go too low or you get dizzy and pass out because you're not getting enough sugar to your brain. And then it can't be too high over long periods of time because it'll wreak havoc on your vessels. So it needs to be in the appropriate range. There are two types of diabetics, type 1 and type 2. Type 1 diabetics are people who, usually younger, we used to call it juvenile diabetes. It's that the body, the pancreas, doesn't produce insulin or doesn't produce enough insulin. And insulin is a hormone that we need to get the sugar out of our blood and into the muscles to be used. And if you don't produce insulin, the sugar builds up in the blood, and 100 years ago, before we developed the use of injecting insulin, people died. Until about 100 years ago. That was it. If you had type 1 diabetes. But only 5 or 10% of people who have diabetes have type 1. Most diabetics have what's called type 2, or you've also heard it called adult onset diabetes. So there's nothing wrong with the pancreas in this scenario. What happens is, over time, if we use an example of somebody who's 20 years old with a normal metabolism, they can metabolize the food that they eat and the sugar that they have in the blood. At the age of 60, they get diagnosed with diabetes. But this didn't just happen overnight. Something happened from here to here to cause this to happen. Let's say at age 20, this person in our example stops exercising and they start eating bad, they start gaining weight, and inactivity may actually be the trigger. Some experts think inactivity is the trigger for diabetes. So they stop moving around so much. So you've got sugar floating around in the blood, the insulin trying to put it in the muscles, but the muscle said, I'm not exercising, I don't need all of that. The muscle becomes resistant to the insulin. So you've heard the term insulin resistant. That's kind of the first stage of diabetes. I don't need all that, you're not getting in here. Well, the pancreas compensates, it makes more insulin and says, oh yeah, you're going to get in there anyway, because we need this blood sugar to stay at a normal level. And so over time, this pancreas produces more and more and more insulin, and eventually the pancreas poops out. I mean, it can only do so much. And the blood sugar, which was creeping up and creeping up, Eventually, at some point, the doctor said, well, now you have diabetes. And one criteria for being diagnosed is if your blood sugar is 126 or higher when you're fasting. So you don't eat for 12 hours and your blood sugar's still 126 or higher. That's one criteria they can diagnose you with diabetes. It should be under 100. Okay? But over time, this just kept going and going. So at age 40, this person may have had a fairly normal blood sugar, but it took more insulin to make it look normal. And then a couple years away from being called diabetic, the doctor said, well, you're kind of borderline. Some people have an issue with that term. They say there's no such thing as borderline diabetes, but it basically means you're knocking on the door and you're almost there. So this is a process that happens usually over a number of years. So how do you know if you're on the road to diabetes or not? And if you flip over the page that I gave you that has the BMI chart, there are some criteria for whether somebody's classified as having pre-diabetes or not. This is also called the metabolic syndrome. It's a cluster of risk factors that often show up together. There's 5 of them. One is how big you are around the midsection. So again, we talked about abdominal obesity. So for men and women, there's different numbers there. If your triglycerides are high, who knows what a triglyceride is? What's a triglyceride? It's fat. It's how fat travels around in the blood. That's what triglycerides is. That's right. We won't go into chemistry, though. HDL, those are the good cholesterol. When your triglycerides go high, your HDL cholesterol goes down. And your blood pressure tends to go up. Anytime you get an extra concentration of something in the blood sugar or too much sodium, you tend to hold on to water, which can increase your blood pressure. And then also a fasting blood glucose, a fasting blood sugar that's over 100. So it's not diabetic, but it's higher than normal. So you're kind of in this in-between range. If you have 3 of these 5 risk factors, then you have what is known as the metabolic syndrome, which is a pre-diabetic state. Now, whether you get diabetes or not, that's kind of where your genetics come in. So in our example, using this person, if both of his parents had diabetes, he may have had diabetes at age 35 or 40 by having all these risk factors. And we used to call this adult onset diabetes, but most children now, so 18 and under, who have diabetes have type 2. They have an adult chronic illness from inactivity and overweight. And so you get that sooner in life, and you show up to cardiac rehab sooner in life. And we're seeing more and more of that. This really is a public health crisis. As the population of the United States, as you probably know, has continued to become more and more overweight, we've seen the same rise in the number of people who have diabetes. So it kind of goes hand in hand. But diabetes is just the tip of the iceberg, that part that we can see above water. This metabolic syndrome is the part of the iceberg that you don't see. More people have this pre-diabetes syndrome than have diabetes. So it's kind of like looking into the future if we don't change some things about our health. So how do you get off the road to diabetes? Same way you would manage these risk factors otherwise. Exercise, nutrition, managing stress, and medicines. And this is an area where usually you don't get treated for a disease unless you have it. But people are starting to be put on diabetic medicines before they're diabetic because we kind of know what's coming up. And what you might see in the future, the not too distant future, is that the criteria for diabetes may be put at 110 fairly soon. I mean, this is already full-blown diabetes. We know that at 110 you're already kind of on the road, so they may change that criteria soon for what's considered diabetes, which of course would make a lot more people diabetic. Okay.
And again, the 110 first.
The 110 is a fasting blood sugar. So you don't eat for 12 hours, you get your blood drawn, and then they measure the sugar in your blood. And it should be under 100. Okay. Now the next risk factor is stress. How many people here have stress? Okay, 3. Well, we know that most of us have stress and more than we need. Most of us have more stress than is good for us. You have to have some just to get out of the bed and do stuff in the morning. But most of us are a little overwhelmed. How many people have stress now that we talked about prediabetes? This risk factor is so important, we've devoted an entire class to it. So I'm not going to spend a lot of time today talking about stress. In a couple of weeks, we have a class called Stress Management, which will go into some of the ways that stress can affect your health. But maybe more importantly, what can we do about it? What can we do to manage stress? And so that's a very important class, and we'll talk about that in a couple of weeks. This includes really a collection of a lot of things that are hard to measure. It's not like your blood pressure. We can just measure your stress and say it's 17.4. It's a little more ambiguous than that. But it includes anger and hostility. It includes anxiety, depression. It also includes not getting enough sleep. We need to rest and recover through the nights so we can do it again tomorrow. And if you don't rest enough, there's a hormone called cortisol that goes up, that gets you up during the day, and it's supposed to come down at night. And if you don't rest enough, it doesn't come down all the way. So if you're getting 4 hours of sleep for the last 30 years, that's probably affecting your health the same way as if you were a hostile person or a depressed person. So that's an important component, and we'll talk about that in a few weeks. Now, another major risk factor, which of course we're going to talk about in here, is exercise or a lack of exercise. I'm not going to go into this one either this hour because next week's class is all about exercise, about the benefits of exercise, about how do we write your exercise plan. Why does it have to be walking, or why do we lift weights and stretch, and how do we come up with the plan, and a lot of things on exercise are going to be on the next class. One thing we know about exercise is exercise is linked with good health. It's also linked with longevity. And we know that people that exercise, we know that people that don't exercise cut a lot of years off their life. And just moving from a inactive person, sedentary job, sedentary at home, to somebody that just gets up and moves around can cut your risk of dying in half. It's very important to be active, and beyond that, you get more health benefits the more you do. So we'll talk about that in a couple weeks. Exercise also impacts your risk factors. So if you did nothing different coming in here than just to start exercising, it would have a positive effect on lowering cholesterol and blood pressure, lowering that stress hormone called cortisol. So even if you had the same stress, if you had regular exercise, that stress would have less of an impact on your health. It helps control, manage, or prevent diabetes. Obviously, when you're burning calories, that's a good way to lose weight. And then we also know that people who are trying to quit smoking or using tobacco are more successful if they exercise than if they don't. Okay? So a lot of good reasons to exercise. I'm going to go into the cholesterol real quick here. There are some numbers that we measure when we're looking at cholesterol. We look at a total cholesterol, we look at your good, your bad, and the fats, the triglycerides. We tell the general population they should get their total cholesterol under 200, which I think sometime in the future we'll probably see this more like 150 or 160. For somebody to have a total cholesterol of 198, I think gives people a false sense of security because it doesn't really do that much to lower your risk. There's a huge study out of Framingham, Massachusetts that started in 1948. It's an ongoing study. It's going on today. It's the 61st year. And back then they took 5,000 people in this town of 10,000. And half of them were women. And if you know anything about research, more than 20 years ago, there wasn't a lot of women were pulled into research studies, mostly men. So what they were looking at is, why do men have heart attacks and women don't? Which is kind of funny, because then they figured out, oh, well, women do too. This Framingham study, what we found is that people who had heart attacks, these were the major risk factors that showed up time and time again. That's kind of where we got the term risk factor and how we found out that these are the things most associated with heart disease. They also found that people who had cholesterols under 150 through their lifetime had an extremely rare chance of having a heart attack. So this really should be a little lower, and you may see that someday. The HDL cholesterol is the good cholesterol, so we want more of that. So that's 40 or greater. It should be over 40. The LDL is the bad cholesterol, and we've been talking about for a few years people who have heart disease or people who have diabetes. The bad cholesterol should be under 100. That number came from some research studies. One in particular was from Dr. Dean Ornish. Has anyone in here heard of Dr. Dean Ornish? Some of you. He's a cardiologist from the San Francisco area. He was the first person to show in a medical journal that you could reverse heart disease. He used no drugs or surgery. He had a lifestyle program. These people ate a very strict vegetarian diet that was only 10% fat. They went through all kinds of stress management and support groups, and they exercised. And of course, he had them all in their, they had chefs and people cooking for them, so it was easier. But the reality is, with this lifestyle study, the people that weren't in his study that just followed their doctor's advice, their heart disease continued to progress. The people in his arm of the study, their heart disease stabilized or reversed a little. So they had like a 70% blockage. He pulled all these people in that had like 70% blockages. They were just starting to get symptoms. The people in his study, their blockage reversed to about 69%. Doesn't seem like a lot, but it didn't keep progressing. It stopped. And besides that small shrinkage of a blockage, it also became more stable, less likely to cause symptoms. Okay. These people got their LDL cholesterols to 100. Now, there's been a lot of studies with drugs, so whether it's with lifestyles or drugs, like statin drugs that most people are on, the lower you got the LDL, the better. So this is really the target that we look at when we're treating cholesterol and trying to prevent heart attacks, is this LDL cholesterol. Now, cardiologists are saying, let's get it down to 70. And we know from a couple of years ago, a collection of all these trials, all these drug trials, getting cholesterol down, that the lower you got the LDL, the less likely you would have a heart attack, less likely you'd have complications. The more likely, if you did come in with a problem, it'd be easier to treat with just a wire and a stent than to have bypass. So 60 was better than 70, and 40 was better than 60. Problem is you got to be on more drugs to get it down that low, but the point is they didn't find a point where you didn't get any benefit. Now, when you're born, your LDL cholesterol is about 40. So I don't think it's going to be driving it much lower than that. In places in the world where they don't have a lot of heart disease, Okinawa, for example, people eat a plant-based diet. They eat fish and rice and vegetables. They're pretty thin, they're very active, and they live to be a long time, and they don't have a lot of heart disease. And their LDL cholesterol is around 60 or 70, just to kind of give you a reference. And the triglycerides, these fats, should be under 150. Now, I'm going to sort of finish what I started talking about at the beginning and draw in some blockages in an artery here. A big blockage and a little one. So we got blood flowing this way, and we got a little blockage there and a big blockage here. And it wasn't that long ago, maybe 15 years ago, even cardiologists thought that these big blockages were the ones that caused heart attacks. And what we found is that these big blockages took so long to build up and develop. It's injury and repair. And if you look at them in a pathology slide, it's like looking at a tree. You look at the rings of the tree, you can see where there was a forest fire and what happened here, and there's a lot of growth at this time. You can see injury, you can see blood clots, you can see all scar tissue. And most of this is hard, fibrous scar tissue. It's been there so long it's calcified. In fact, there's prevention screenings they do called calcium screenings. And they can estimate how much, if any, heart disease you have by your calcium score. So these are pretty stable. These are less likely to cause a heart attack, these big blockages. They may cause some pain. This will be where they go in and do a stent, or they'll do a bypass. They'll take a vein or artery and put it just beyond the blockage and bypass it, so you get blood flowing this way. But these little ones are the ones that are the most unstable, the ones that are most likely to sort of burst and cause a heart attack. These are mostly inflammation, cholesterol. It's the softer, goopy stuff. And if you want to think of it in terms of the outside of the body, it's kind of like a blister. This can swell up, and things like chemicals and toxins and stress hormones and high pressure can irritate a little blockage and swell it up. So it's like a blister that's gotten tight. And if you let it cool off, it shrinks a little. So this could be a little blockage, or it could be a little bigger the next day. And if this thin cap that's covering it were to crack or burst, you get all this stuff coming inside the artery, and then all of a sudden you get all these little platelets trying to stick together. The platelets are the little things in the blood that makes your blood clot. So these start sticking together, and if they get to stick together and this clots, you're not getting blood this way or this way. Everything downstream is blocked off. This is a heart attack if these stick together. And as they're trying to stick together, that's a heart attack trying to happen. And if you're on aspirin, when these things are trying to stick together, your risk of having a heart attack is cut in half. So aspirin is an antiplatelet, keeps the platelets from sticking together. Aspirin is also an anti-inflammatory. So if you take it chronically, it can help prevent this from swelling up in the first place. So aspirin's kind of a wonder drug. And if they invented it today, it would cost a lot more than your cholesterol drugs. The cholesterol drugs, though, the statin drugs, Zocor, Lipitor, Crestor, those drugs lower your LDL cholesterol. We know that's important for a number of reasons. It also can suck all the little LDL cholesterol that's kind of got stuck in the walls of your artery. It kind of sucks them out. It allows your artery to open and close and function like it's supposed to. So even if the blockage, even if you have a 70% blockage and it doesn't change a lot, but you've lowered your LDL cholesterol, your artery works like it's supposed to. when you have a lot of blockage in an artery, and then you start to exercise, instead of opening up like it's supposed to, sometimes it'll constrict. So lowering your LDL cholesterol, which can be done with medicines and diet, and also exercise can make your arteries open and close and function like they're supposed to. The statin drugs, besides doing that, they've found in the last couple of years also have anti-inflammatory properties. So even if your cholesterol levels were already kind of low, and you may question, well, why am I being put on a cholesterol drug? My cholesterol's low anyway. Well, you got some blockage in your artery, and we're trying to stabilize what's in there and prevent a heart attack. That's why you're on the drug. That's one of the reasons you're on the drug. Okay? So it's important to keep taking the medicines you're on and know why you're taking them. And let your doctor know before you change anything or let them know you're having side effects. So the last thing I want to mention real quick is the risk factor of blood pressure. What is the ideal blood pressure? What is the goal? Well, okay, 120. What's the bottom goal?
80.
80, good. It should be that or lower. The lower the better. The lower it is, the lower your risk. Some people do fine with a top, we call that the systolic, the bottom's the diastolic. A systolic blood pressure of 90, some people have no problems with that. You know, they don't get dizzy, or maybe they do a little when they've been sitting for 3 hours, but the lower the blood pressure, the lower the risk and damage to your arteries. Now, this is the guideline for every adult. It doesn't matter your age or your gender or anything else. That's what you shoot for. And you know, you may chronically be high, and your doctor may be happy to finally get it to 140 over 90, but 140 over 90 is the point where we call it high. That's where we consider it hypertension, is 140 over 90. So if it's chronically 140 on top and or 90 on the bottom, that's the point where we call it high blood pressure. If it runs in between there, we call that pre-hypertension. And it just means that you're at risk of having high blood pressure later in life. Some of the experts, as I mentioned a couple of these things, they're going to start getting a little more strict with what the numbers should be. There are some proponents of saying that anything over 120 over 80 that we're going to call hypertension. We'll call it the first stage of hypertension. So the next time you get a 126 over 82, think about that. Another thing to shoot for. So the two numbers, do you know why we have two numbers?
One's resting and one isn't.
Well, one's your heart's resting. Yeah, so the top number is when your heart squeezes, pumps blood, pressure goes up. And as your heart's relaxing and filling with blood, pressure comes down until it squeezes again. So it goes up to 120, down to 80. And we're not a machine, so you're going to get a different number every time you change it or check it. And you may get different numbers every time your heart beats. Your heart may squeeze out a 126, and then it may squeeze out a 118. And it's dynamic. It changes throughout the day, and it changes each time we check it. Okay? So these are the major risk factors for all cardiovascular disease. And I'm going to pass around the handout that just has a summary of these. So, and with diabetes, these are the 10 things to know, and of course the 7 things to really focus on. And there are other things that you can look into for good health. A lot of people look at herbs or other alternative types of treatments. But if you're not exercising and you're still smoking, the herbs may not do you a lot of good. So these things first, and then look what else you could do to improve your health. So that's it for our talk today, and have a good day.